Hi everybody, it's Ciaran here from CP Clinic. Myself and Niall are going to do a little bit of a live Q&A this evening. Hopefully the first of many if people find it useful. We've a good few questions to get through, so we'll crack on. We'll keep it nice and relaxed, and we'll see how we get on. Okay, so first question: do you take on rehab or S&C students for placement? We do. We have had numerous students over the years that would have done placement here with us from various different universities. But obviously it's done on a case-by-case basis because we do get inundated, and so it is something that we do, but obviously we're quite limited as to how much we can do because we only have room for so many, number one, and then number two, obviously there is some patients who maybe don't always want a student in the room with them, etc., which can limit things as well. But to answer the question, we do take on students for placement. Next, what are the most common injuries you see in the clinic and how do you treat them? So for me, it's probably back pain as an osteopath. People usually view osteopaths as back guys and gals. Whether that's true or not, I don't know, but that's the way we're viewed. So probably back pain is the most common thing that I would see.
Yeah, for me it's probably slightly different. I see a lot of knees, and probably on both sides of the spectrum I see a lot of people post knee replacement. So we're building up their strength post surgery to get them to be able to do everything they need to do. But then on the other side we're seeing a lot of athletic population with males and females regarding ACL injuries. So knees will be my most common.
Cool. Do I need a referral from my GP to book an appointment? No, you don't. You can book directly. You can book on, I call on reception, or reception will look after you. You can book through Facebook, book through the website, Instagram, and those. Obviously, if you're a little bit unsure as to what you need to book, you obviously check it out online, but you can just call Maura on reception because Maura, I think she knows more about the place than I do, if I'm honest about it. So Maura will definitely be able to help you out, I'm sure of that. How do I know if I need physiotherapy or osteopathy for my pain? That's a good question. So the long and short of it is both are applicable in various different situations, in most situations. However, some conditions maybe respond better to osteopathy versus physiotherapy. So obviously this is completely personal preference as well. But for like acute injuries and for pain relief, symptom relief, osteopaths tend to be very, very effective because their hands-on manual therapy techniques are exceptionally good. So they tend to be very, very effective in that acute pain phase. Not that they can't help from a long-term perspective, of course we can. Whereas physiotherapy, while it can be very manual, hands-on based, it's also very exercise-oriented. So physiotherapy from a longer term perspective may be a better approach, but it's very realistically they're two different things. So a bit of a multi-modality approach is probably the best way.
Yeah, they complement each other, I would say.
Absolutely complement each other. And like if you look at big sports organizations in the UK, all of them use physios and osteopaths. In the States, it tends to be physical therapists, which are basically physios, and chiropractors. So there's some sort of manipulative therapy in there. So look, generally speaking, it can be either or. But one person who's very, very good again at distinguishing who might be best to see it is more on reception. She's very, very good over the years of learning who's best to book in with. So if you have any questions or queries or you're unsure, I think give Maura a call for sure. Can you explain how dry needling works and who it's suitable for? Okay, so we could talk about this. We could give a lecture on this one, but we'll try and keep it fairly simple. So, how it works? I mean, effectively, it's like acupuncture in the sense that you're using acupuncture needles, single-use sterile needles, and they go into the tissues. Okay, so dry needling versus, we'll say, Chinese acupuncture. Chinese acupuncture is based around energy meridians in the body, and it's quite shallow needling, whereas dry needling, whereas like orthopedic dry needling and trigger point dry needling are all kind of the same kind of thing. They will be, you actually are needling into the muscle tissue, whether it's a trigger point or a hypotonic muscle or something like that. And it's primarily used for pain relief or to relax muscle, or even switch on muscle if it's not toned enough. So I kind of view dry needling as it can do a few things, but on a really basic level, you put a needle into a muscle, for example, it really heightens the brain's awareness that something's going on in the area. So when you've got a long-term chronic problem in your shoulder, for example, you put a needle into that area, it really makes the brain sometimes can get a bit lazy in healing, and this is just a great way to really spark that healing process. And then also, some people will notice that they've had it done occasionally. It can be, when a needle goes in and hits a certain point, it can be a little bit tender. That's actually very, very beneficial in the sense that does give you a kind of a sharp little twitchy pain, but that actually will block out a lot of the long, dull, achy pain that people typically experience with injuries. So, so that's kind of the difference between acupuncture and dry needling. Who's it suitable for? Honestly, anybody that has any kind of musculoskeletal pain. Generally, does, of course, increases blood flow, which is how the body is largely going to heal itself. If you have the ability to heal yourself, acupuncture or dry needling are both really useful things. So yeah, I hope that answers that one. What's the best way to speed up recovery after a sports injury? You go ahead there.
Yeah, so I suppose originally people would think after sports injury that we need to rest for a longer period of time. Now the most effective approach is for the first 48 hours we protect that area, so it won't do much strenuous exercise. But after about 48 hours we actually want to get moving again, and like what Ciaran just spoke about, we want to get blood flow to the injured area again to promote that healing process. What people might know is within a few days of an injury, we can lose a massive amount of strength and range of motion, more so strength. So what we're trying to limit is our muscle strength loss and our range of motion loss. So within that 48 hours, we actually want to start exercising again. So for example, one of the most common sports injuries is a hamstring injury. So after 48 hours, we would want to get moving again. We might start with some bridge exercises where you're holding for a period of time of 40 seconds, and we might start with some light squat movement and maybe just a little bit on the bike as well. So the most important thing on my end is that you need to actually start that recovery, like within that 48 hours, get moving again and start that recovery process. Anything else, Ciaran, you could add on to that?
I mean, the big lesson there really is if we look at changes in how we approach injuries over the last 20 years, I mean, that's a really big one. So, you know, when I was a child, no matter what injury you got, you were put in a cast or a sling, or you were really wrapped up and told to rest, and that's just factually wrong. In fact, it's quite rare now that people will immobilize in any long periods of time. Okay, so that's a big lesson, that people can actually start working with something like an oil way sooner than most people think, actually. Then just to add to what Niall was saying, like from a nutritional perspective and a lifestyle perspective, really don't overlook that. So like once if you think about what is an injury, if we'll say the hamstring example, what is a hamstring injury? Typically it's going to be a tear to some amount of muscle fibers. So obviously you need to repair that muscle. So we all know, for example, one macronutrient that's really important to repair muscle is protein. So you have to make sure that you're at least getting an adequate amount of protein, if not maybe a little bit more. And then if we think about the inflammatory response to an injury, we want to keep inflammation under control. So again, like we can talk all day about this, but from a nutritional perspective, avoiding really bad processed sugary foods, you know, taking things like an omega-3 fish oil, collagen supplements work really, really well, things like vitamin C and collagen are kind of the two that go together, work really, really well. And then most importantly, and it just happens to be one of my, anybody that knows me, I'm an early bird, so I go to bed early and get up early every day, because sleep is so important. And I know in every facet of your life, not just from an injury perspective, but certainly from an injury perspective, when do we heal and when do we repair tissue? During our sleep. So if you compromise your sleep, you will really hamper your ability to get better. And I remember hearing the phrase years and years ago, an hour before 12 is worth 2 after 12. Okay, so going to bed at 10 o'clock and getting up at 6, which is kind of what I do, is much better for you than going to bed at 12 and getting up at 8. Okay, so getting the nutrition right, getting the sleep right, really, really important.
I suppose just to add on to that, if you get your nutrition, you get your sleep right, and you're starting to move in those first 48 hours, you're actually going to get back to your sport a lot quicker than waiting for those extra few weeks. So you've reduced your muscle mass and strength, you're starting to build. You've probably heard before a hamstring injury, a 2B is an 8-week rehab process. Well, if we started in that first 48 hours, we might turn that into a 6.5 week rehab process. So that's a game changer, especially when club championships and everything come on. It's trying to start that process early days.
We're determined not to talk about hurling tonight. There's been a few comments have come in about hurling, so we're determined to keep it strictly professional. So, next question: how many sessions does it usually take to see results? Genuinely, that's very, very dependent on the situation or the patient, but it can be as soon as one session. There's no question about that. We would very, very regularly have somebody in for a session and they're completely pain-free after one session. Now, those call into question the debate of after one session and somebody's in quite a bit of pain, you treat them and then they're pain-free. You know, is that necessarily a comprehensive treatment? I would argue it's not. You know, we often say that pain is the last to arrive and first to leave. Okay, so what that basically means is you can have a problem, not have pain, then you get a pain. Okay, you treat it, you get rid of the pain and it's gone first, but it doesn't mean the problem necessarily is gone. So, you know, to be comprehensive, one treatment is not always sufficient, but you can get results, and I mean significant results after the session, but obviously it's very, very dependent. And then there's lots of people we don't help and can't help, but we'll be very upfront and honest about that. We're not into getting patients back unless we're able to help them. And thankfully, we have enough people seeking our help that we don't need to get these people back that we can't help them. So, all right. What is the difference between a sports massage and a regular massage? So, I mean, first of all, sports massage tends to be slightly firmer, deeper, and stronger. Massage strokes will be a big difference, and like obviously, regular massage can be used purely for relaxation purposes and stuff. So there is differences in that sense. Now again, the practitioners here, even though it's a sports massage, you know, there is some patients that clearly just want to be relaxed, but also maybe have some body part that they want to get a deeper massage on. So, you know, we can kind of mix and match a small bit, but generally a sports massage is going to be deeper, firmer, and it's about flushing out those tissues and getting fresh blood into the air to try and speed up healing and recovery. Versus regular massage, it's actually a very broad treatment that it could consist of a lot of different things. So I hope that answers that.
Few people are having trouble with sound, so I wonder, you're plugged in.
Is it better if we hold it there? Give us a thumbs up if that actually works better. Is it a shot? Yes. All right, let's try that. So, what is the difference between K-laser therapy or shockwave therapy? So, two really cool pieces of technology that we have here, but they're also quite different. Okay, so like if we take shockwave therapy, for example, you know, what shockwave therapy effectively does, it sends acoustic sound waves down into the tissue, which actually mildly inflames and irritates the tissues, but not all irritation and damage is actually a bad thing. If you think about it, when we exercise, that's what we do. So it sounds like it's a bad thing, but it's not. Okay, so it basically will cause some mild inflammatory response, and we typically will use that on stubborn conditions. Okay, so if we take a very typical scenario and we cut our hand, you know, do a manual work or something, there would be a much better, there was just a normal, you go through the normal 4 phases of healing from inflammation all the way through to remodel, all that's coming back to perfectly healthy tissue. The problem with a lot of chronic long-term problems, for example, like tendinopathies, etc., is that the body just gets stuck in a phase and keeps going back and recycling. So what the shockwave can actually do is, it's like rebooting your computer sometimes. It can actually bring you back and inflame the area, which again, like the knee and earlier, the brain then realizes, oh, we have a problem here, and it just goes through a healing process and then hopefully goes all the way through to the far side. Now, always with shockwave therapy, it needs to be paired with loading, and obviously that's Calf's baby. Okay, so and the rest of the rehab team here. So it has to be paired with loading because that is always the foundation of recovery, particularly attendance. But that basically is kind of an idea of what shockwave is. The K laser is a class 4 laser therapy that we use here, much nicer than shockwave therapy. So with laser, you just feel a lovely, nice, warm heat. And what's happened there is the light energy is penetrating into the tissue, and what it effectively does is it increases the mitochondria, which is the energy storage from the cell. That actually increases energy production. So if your body has an ability to heal itself, which obviously we're banking on, this will speed up the energy production. So it will actually help your body heal itself. Both of them are analgesics, so both of them are painkillers. So they're really, really effective for slightly different reasons. A K laser, I think the K laser, its methodology is what we call photobiomodulation. In plain English, it's like sunlight on the flowers. Okay, flowers don't grow without sunlight. The human cell responds to light energy, so the K laser is just a really effective way of getting a hefty dose of light into the cell and increasing energy production. So, but again, both of these typically need to be paired with a proper rehabilitation program.
Yes, I suppose one thing with the laser therapy is good is that someone who's struggling with movement to start off, that we're actually getting that blood flow, we're getting that thing, that we're getting the healing products that we would get out of exercise, which promote them to be able to exercise. And then the shockwave therapy, really good, helping to remodel the tendon, and heavy load is also helping to remodel the tendon. The tendon's made out of collagen. We get different conditions. Some are inflamed over a few weeks, some are deteriorating over a few months. So it can depend on the exercise approach and the intensity of the shockwave as well. But like Ciaran said, both have to be paired with regular exercise.
The other thing about K laser therapy, it's quite versatile in that it can be useful for tendons, really, really powerful on ligaments. We can use it for muscle tears. We can use it in acute phases, unlike in the shockwave. We can use it even for arthritic joints for symptom relief, whereas the shockwave is not as versatile in that sense. But if you have a tendon problem, the shockwave maybe is what you want. So it does depend on what the complaint is. But both very powerful pieces of technology. What should I expect during my first visit to the clinic? Well, the first thing, you will be greeted with a massive smile in reception. Whoever is on, typically Maura, will definitely greet you with a smile. So typically you're given a consultation form where we just gather a little bit of details, and then the practitioner will take you into the room and you'll get a full case history and consultation, where we go through everything about the injury, and we also do a bit of a health status, because we need to make sure that if we assume you're coming in with pain, for example, we need to make sure that your pain is coming from what we call a musculoskeletal problem and not a systemic body problem from an organ, etc., disease process. So we do a full health screen as well, and then typically in 99% of the time you will actually receive treatment on your first day. Okay, there's times obviously where we may not be happy during the consultation and the patient may need to be referred for whether it's further imaging, further medical testing, etc. Or we just can't help you and we'll just tell you. But typically you will actually receive a treatment. Then we will try and explain the treatment plan. So for some, that treatment plan might just involve, for example, if they come to see me as an osteopath, there are conditions where we just might do a couple of osteopathic sessions and that's it. But very often I will refer people in and out to the rehab team as well, because almost everybody needs a bit of coaching around exercise, rehabilitation, and health and well-being. So, you know, the rehab team, that's their area. So, you know, the treatment plan is a big thing. We try and set out the stuff, what it's going to look like, so that people are quite clear on what the plan is. There's nothing worse than the confusion of just coming back and there doesn't seem to be any system or plan to what's happened. So we like to lay that out clearly. And then, yeah, I mean, that's pretty much it from our perspective.
Yeah, it probably on the treatment plan also on my end and on our rehab end, it depends on the person's goal and how our treatment is or the intervention. So we see a broad range of people. We have some people who want to get back to contact sports. We have other people who just want to be able to play with their grandchildren. We have other people who just want to go for a hike. So as a rehab team, we design a set program and set benchmarks for that individual to meet so that they're able to do that. And generally every 2 or 3 weeks we'll check in and make sure they're working towards your goals, and we set them some new goals.
And that's a good point as well. That, you know, I cheekily say to patients sometimes, listen, if you were playing with Man United, because they're throwing stuff at the camera, right? But if they're playing with Man United and time and money clearly is not an object, then we move them in here and they'll be getting rehab and they'll be getting treatment every day. So obviously the plan has to work for the patient. So some patients, you know, are just adamant. You know, we often get athletes maybe have come up to big events or whatever, and they're like, we do whatever we need to do basically. And then we have other people where we just need to be realistic in terms of the treatment plan, that maybe they can only, you know, whether it's a financial thing or a time constraint, that can only come in a couple of weeks or once a month or whatever. So obviously the plan has to make sense as an agreement between the practitioner and the patient, depending on their circumstances. Next is, are there any simple exercises I can do at home to help with knee pain? That's a broad enough question. So, but
yeah, it probably depends. First of all, why are you getting knee pain? So, knee pain can be caused by various reasons. A lot of the time, I'd say nearly 90% of the time, we've got an imbalance in strength around our knee. A lot of the time we can have a weakness in our quad muscles, which are involved in extending the knee, and also a bit of weakness in our posterior chain. So basically, then our knee is struggling to tolerate the load that we're putting through daily. So if that is the case for the person, and if that was assessed and we said yes, then absolutely you can do simple exercises to help out your knee, and it can be really simple. We're in a gym here at the moment, but we actually can do things without any equipment whatsoever. You can do a simple movement like getting near your kitchen chair and can you sit down and stand up there to get movement and blood flow to stimulate the nervous system to try to strengthen your muscles up. Also really good when we find with people who are struggling with knee pain is the bike is a great alternative. First of all, it gets again blood flow, it gets the muscles firing, and you feel a little bit better about yourself after the exercise as well. So there's definitely exercise you can do. Sitting down and standing up is probably your first and foremost. Really simple one. It's a really good sign of your function in general for your health as well. So as we age, we lose a bit of strength, we lose a bit of muscle mass around our thighs. So it's a real good gauge of seeing where our strength and our lower limb health is. So absolutely.
I was interested to read a paper today that was talking about that as a predictor of longevity, your ability to literally get in and out of a chair without using your hands. It's a really good predictor of how long you're going to live. So best to get that sorted.
Keep squatting, I think, is
absolutely. And then the other thing, the point that Niall was making is important is, you know, we're in a gym, we're in an environment with all the equipment and all the technology. Like the best exercise the best exercise is the one you'll do. Okay, so we're not here to sell somebody on the notion they have to go join some fancy gym and spend a fortune. Oftentimes our rehab protocols require absolutely no equipment or some simple exercise band, or, you know, so the stairs at home, there's many different, a chair, we're talking about here, sitting on a chair. So it doesn't always require fancy, expensive equipment, I suppose, is the point that we're making. How does the isokinetic dynamometer testing work, and who should consider it?
we're onto the fancy equipment now.
This is fancy equipment, yeah.
Look, we have a fantastic machine brought in last year, and we use that first and foremost to test strength. So the beauty of it is we can test strength in isolation. So we see a lot of knee injuries, especially ACL injuries. So we use the machine to test your quad and hamstring strength. And we also are comparing the left and right side. So we're seeing the difference between our left and right side, so our non-injured and our operated side. So someone going through an ACL process would be getting tested every few months to see are they reducing the gap in their strength. What the other beauty of the isokinetic testing is, we're getting your strength with respect to body weight. So this could be someone who's not even injured, and we're seeing what their capacity of their quads and their hamstring is. So if you think about back to the sitting down and standing up, that's down to your quad function. So anybody could come in and be tested on their quad function to see how strong they are relative to their body weight. And there's certain markers you should be depending on what weight you are. The other thing in regards to the IKD is that we can find the range of motion where your weakness is. So this is a game changer. So we're testing, let's say it's an ACL, and we're testing a quad, and we can see what range of motion the weakness is in the knee. Is it in the straight position? Is it in the most flexed position, or is it halfway? So the beauty of that is then we can isolate that straight away during the rehabilitation. So it's just a game changer, because otherwise you're assessing and you're looking at the gym and you're not fully sure, but this is telling you the numbers. There's no hiding place with the numbers, so you're getting the data, and then you can again reassess in a few months' time. The beauty of it too is not just the knee, we can do hamstring, and quite a lot of shoulders working there as well. So you work on especially rotator cuff repairs or post-surgery, and Achilles as well. So you're getting your strength with respect to body weight and your capacity for all those different injuries. So it just really, for us, I would say, it eliminates a bit of guesswork. You're getting precise data, you're getting exact numbers. The patient loves it because they know exactly where they are in the rehab process. So they know, okay, I've 20% to improve on before I return to run. So we use it as a marker for our next stage of rehabilitation. So I just think it's a game changer over the last few months.
It's the isolation is a big thing. So I know Niall's already said it, but I could do a back squat, or I could even do, let's go with a single leg. I could do a split squat, and I could appear level on both legs. Okay, but how do we know? Like if I do a split squat, we're getting a contribution from glutes, hamstrings, quads, even calves. We're getting a bit of a contribution from a lot of muscles. How do we actually know the breakdown? How do we not know that maybe it's my right glute is really strong, but it's my left quad is really strong, but I still look like I'm the same doing a split squat? So this thing can really isolate that. And I don't know if people out there are the same as me, but I kind of have to know. I mean, the idea of not knowing something, that would really bother me. So if you don't know and you don't have data, then you don't really know where you're going. If you don't know where you're going, and your road will take you there, as they say. So you just can't be having actual data to support it. And a lot of people like those numbers, as you said. So you start off with a discrepancy of 40% discrepancy, when they see that get to 30 or 20, it builds confidence as well as the physical capacity. So yeah, I mean, it's just a phenomenal piece of equipment, really. What is the best treatment for tension headaches or migraines? So I mean, first of all, tension headaches and migraines are different things. What I would say is, I suppose from our perspective, we're trained first of all to know the difference. Headaches can be anything from, what we would treat, which is cervicogenic headaches, which basically in plain English means it's coming from the structures of your neck and it's giving you a pain in your head, which is what we would treat, and all the way up to obviously some really sinister things. Okay, so again, we are trained to, as much as possible without doing a brain MRI, we're trained to be able to tell the difference, okay, or safely screen you to tell the difference. So so that's the first thing, is to make sure that the headache is safe for us to treat. Then In terms of treatment modalities, again, if it's coming from the structures of the neck, okay, from a manual perspective, there's lots and lots of things we can do. Okay, so it can be anything from various different muscles in the upper back and neck to the actual, there's little teeny tiny muscles at the base of your skull that actually attach to the dura, which is a layer that goes around your brain and spinal cord. So there's a lot of different things can actually give you a headache that's just a muscle or a joint. So from an osteopathic perspective or a physiotherapy perspective, we obviously can treat those tissues with manual therapy, hands-on therapy, joint manipulation. We mentioned dry needling, really effective for that. And then the big question will be to bring in the likes of the Niall. The big question is, well, where is this problem come from? Why have they got this muscular problem? And invariably, it could be a simple explanation like their ergonomics at their desk is horrendous, which would be a very simple explanation. It could be they have a really bad mattress, a really bad pillow, bad driving setup, or a muscular imbalance that, quite frankly, is not going to go away unless you specifically target. And then again, that's where the rehab that's coming in.
Yeah, and probably with the that I'd say the exercise front, a lot of time we forget about the neck itself. People don't realize they've got muscles in their neck and they're very, very important. And we go around day to day now looking at our phones and looking at our screens, and we're looking down. We tend to gain a weakness around our neck flexors and neck extensors. So on our end of things, we're trying to work on that flexion strength, that extension strength, trying for the person to regain their control of the neck, because sometimes with these kind of headaches, they struggle with movement. And then stripping back from there again, then you're working on the shoulder and the shoulder blades and trying to regain function there. So there could be many reasons behind it, but I think again, it's the combination of both treatments that we have the best.
And very much, I mean, this can be obviously general population, so obviously tons of people that don't play sports have this kind of thing. But then there's the whole talking about necks. I mean, if you're in a contact sport, I remember Charles Pollock, the great strength coach, used to say that if you play like rugby or GAA, for example, neck training is like life insurance. That's what he used to say. So we are seeing so much concussion, it's crazy. And there is really good data that's absolutely black and white that if you train your neck and you have a strong neck, it massively reduces your risk of getting a concussion. Because as we've seen, once you get a concussion and it's not managed correctly, it can be a really long-term problem. So yeah, that's that. I had an operation on my back 2 weeks ago to fix decompression on the spine. How long do I have to wait before seeing a physiotherapist?
I think similar to our sports injury, you actually want to get moving as quickly as possible. So I would say within the first week. Sometimes it can be 2 weeks, but depends on the guidance given just post-operation where physio at the hospital. But I would say within the week, is if possible. Again, what happens post-decompression of the spine is we're quite sore, first of all. We're quite stiff. And if we keep going on for weeks without movement, we lose more muscular strength, more control, and that's going to cause us problems when we're trying to regain our function in the future. Also, I think post-surgery can be a quite scary time and scary place, and I'm seeing that more so over even the last year. People are worried that, is this normal? Should my back be this sore? Should I be able to reach my toes? Should I be able to sit down and stand up? These are all, everyone is going through normal, but I think they get a lot of peace of mind and going, okay, this is normal. And I think what we try to do then is map out this is a week post-surgery, this is what 3 weeks post-surgery is going to look like, this is what 6 weeks post-surgery is going to look like. So the person comes then with peace of mind knowing what the plan is. I know it is okay to have pain. Pain doesn't mean damage. It's just from the surgery itself, and it can take 3 or 4, sometimes 6 months, or sometimes longer for that pain to go. But I would say, yes, absolutely, see them within a week, if possible. get moving quickly, as in just gentle exercise that physio will give you, and then it's as I said, the mental side of things, giving yourself a support network and giving yourself a bit of peace of mind. These are normal things.
Yeah, so just to add to that, if you think about it, your orthopedic surgeon or neurosurgeon, whoever does the procedure, we all know how time constrained they are. Okay, so people obviously we regularly have patients coming in saying, I paid that person €250, €300 for 2 minutes or whatever they say, right? And so there are a lot of time constraints, they're extremely busy. So actually being given the time in here to explain the procedure and to explain the process is invaluable, because people, I mean, all people can create all kinds of extremely bizarre images in the brain of what's going on with their back, and it's extremely unhelpful with the recovery. So they build all kinds of bad pictures, and obviously speaking to somebody that knows can eradicate all of that stuff. The other thing is, to our doctor and surgeon friends in there, we treat a lot of doctors here, so some of the lesser enlightened doctors, sometimes I think they think that every patient ever comes into a clinic like this is going to be, like physically and manually manipulated and, really heavily treated. We're well skilled on this stuff. We know how conservative we need to be early doors. So I would say, don't be too put off. Obviously, you follow the advices of surgeons, but don't be too afraid to come in early, is what I'm saying. We know what level of treatment needs to be at, if that makes sense.
Yeah, I think, personally, I think sometimes surgeons play it safe, and they might say, don't see a physio for the first 4 or 6 weeks. And that is just for, look, I think surgeons just looking at trying to reduce pain and trying to make the person feel good. But we're thinking long term. We're thinking 6 months down the line, 8 months down the line, 12 months down the line. We want this person to be able to do whatever they're looking to do, whether that's, I say, go for hike, go for cycle, whatever they want to do. And that plan needs to start early days. Because similar to what we're talking about, the muscle injury, if we start early days, we recover a lot quicker. So it's the same process.
Is osteopathy safe for pregnant women? Yes, is the answer. Again, osteopaths, we're quite known for treating a lot of pregnant women, and then depending on the osteopath, if they're a cranial osteopath, they may treat babies a lot as well, newborn babies, any kids. So I suppose the first thing is, are they safe to treat? An osteopath is actually allowed to treat a pregnant lady from conception right through to the time they go into labour. As soon as they go into labour, no more osteopaths allowed, right? But up until that point, they can treat, okay? The other thing to know is that an osteopath, again, a little like the headaches, is trained to know what we call pregnancy red flags. So obviously, unfortunately, things can go wrong during pregnancy. So if somebody's coming into us with pain as an osteopath, whether it's back pain or wherever the pain is, we need to make sure that pain is, again, musculoskeletal pain coming from a structure, rather than obviously something that we don't want to talk about, obviously. Okay, so first of all, they're trained to screen for that. Then the other thing is, obviously, depending on the trimester, I just tend to treat most of the pregnant ladies, which I treat a lot of, very conservatively and sideline most of the time. And I actually do it even in the early stages when they don't have to necessarily be sidelined. I just do it anyway, just to get into that habit and start treating them that way. And we have great success, and we treat a lot of pregnant women. Again, the rehab side of things is such a biggie. The stronger you are throughout your pregnancy, typically the better the labour and the faster the recovery. So again, we would send a lot of people into the rehab team during pregnancy. So, do you offer treatment plans for long-term conditions like arthritis? Absolutely. So again, from my perspective, as an osteopath who's more kind of hands-on, we would definitely use kind of manual therapy, whether it's the osteopaths and physios here, using manual therapy for symptom relief, pain relief, improving the range of motion of the joint. And sometimes if a joint is quite painful, the patient is actually too much pain to move it. We'll passively move it. There's all kinds of things we can do to help the patient that has arthritis. But again, I know I don't sound like a broken record, exercise-based approach, absolutely vital. So again, manual therapy, whether it's osteopathy or physiotherapy, without the exercise, you're only getting half the treatment. You've got to have the exercise-based approach from a long-term perspective.
Yeah, exercise is so important for people with osteoarthritis, or for arthritis in general. It just depends whether it's osteo or rheumatoid, how we treat it. And it's regular exercise. It's trying to, I suppose, the people a lot of them come with this arthritis and haven't done a massive amount of exercise because they're quite afraid. They think a lot of the time it's bone on bone and they feel like they're doing more damage, while also, but they're actually doing more damage by not moving and not doing exercise. So apart from trying to strengthen up the muscles to support the joint through exercise and through resistance training, we're also learning. We're also, what the research is saying, we're actually starting to increase bone mineral density through weights training as well. So we're not just treating the muscles, but we're actually loading the bone for to increase the density and thickness.
Yeah. And even like if we take, for example, arthritis, if we take a knee joint, because the knee arthritis is extremely common, there's really clear evidence, if we're talking about exercise, there's clear evidence that says a 10% reduction in weight equates to approximately 50% reduction in symptoms. Okay, now I suppose most people, when they hear that, they assume it's literally to do with the body weight compressing through the knee, and I'm sure that is a factor. But actually, one of the big reasons they believe that it gives so much symptom relief is actually just the tissues are so much healthier and the patient is getting so much stronger. That's why they get the symptom relief. It's not just the mechanical weight. So, look, exercise, rest is rust. Okay, if we rest, we rust. Exercise, I once heard a guy say, motion is lotion, right? You gotta move, you gotta exercise. So, expert advice on that is so important. Do you offer evening and weekend slots or weekend slots? We do. We offer both. So we do some late evenings here, and Quiva typically does a Saturday morning, afternoon. Obviously, we're very busy anyway. But obviously, the evening and weekend appointments certainly go very quickly because people are typically off work. So if you want to book in, you better book in advance on that one. We're nearly there, I promise. We have a few more questions. I have sciatica and struggle with constant pain down my leg. What treatment can help, and how long does it take to see results? Okay, so this is a word we hear a lot. Okay, so a patient will come in and say, I've got sciatica. Okay, so the first thing I'd say about that is that's not really a diagnosis. Okay, that's like saying I have a sore arm. Okay, or I have an infection. It's not actually a diagnosis. Okay, so the sciatica, basically the idea is it's something to do with the sciatic nerve, which is a big nerve that runs from your back all the way down to your foot. Okay, the back of the leg all the way down to the foot. So what it doesn't explain though is what is actually causing the sciatic nerve to be a problem. Okay, so the typical things that will cause that will be the nerve is maybe getting irritated by a disc in your lower back. It could be that through degenerative changes in the spine, they're getting what's called stenosis, which is narrowing of a hole or a foramen, and that can choke the nerve. Or it could be none of those things, and it could be something like a piriformis syndrome, or a sacroiliac joint dysfunction, or something like that. That's the nerve is getting caught in the buttock or the glute. So sciatica is a really bad diagnosis. So finding out which one of those it actually is, it would be the first thing I'd say. And then what treatments can help and how long does it take to see results? Again, we have patients that would have had violent leg pain. We could treat them once and they could be 80% better after a session. However, we've also got patients that no matter what we did, could not help them. Okay, so I don't want to be vague, but it's a very long, it's a big scale and it could go anyway. But a typical situation, again, manual therapy exceptionally good to mobilize the spine and to loosen out the hip musculature and free up the glute muscles that might be impinging that sciatic nerve. And then the exercise-based approach then is extremely beneficial, okay? And not only is it beneficial, it's kind of one of my pet peeves at the moment. A lot of people, as soon as they have this, they want to get an MRI and they want to see an orthopedic, okay? So there is guidelines around this kind of stuff, okay? So the guidelines, depending on what country you're in, they're typically all pretty much the same. So the typical approach is manual therapy, which is whether it's osteopathy, physiotherapy, whatever. It's manual therapy with an exercise-based approach for approximately 6 to 8 weeks. And in the event of that not working, then you move on to imaging and you move on to whatever protocol is next, whether it's an orthopedic, an injection, or eventually in the failure of any success, maybe some sort of a surgical procedure. But again, you only do those things after you've tried the conservative methods. And conservative approach has been proven to be extremely effective. Okay, so you don't want to go get the MRI until you've tried the conservative approach. Okay, there will be certain red flags again in that 6 to 8 week period. If something happens that we obviously are trained to know that don't like this, we get the scan sooner. Okay, but typically you don't want to get an MRI straight away. So what we find with MRIs, and this is a big thing in medicine over the last 10 years, is a real reduction in the amount of MRIs that the medical people want done. And the reason for that is what we call insignificant findings. So I got absolutely no back pain, thanks be to God, right? You have no back pain. You MRI the two of us, he's old, I'm young, right? The chances of us having discrepancies or having conditions on a back MRI extremely high depending on your age. Okay, so there's probably a 50% chance that you'll find like a disc bulge in my back, even though I've got no back pain. So if I get back pain and we do an MRI and we see a disc bulge, now we tend to blame the disc bulge, even though I had a disc bulge yesterday, I had no back pain. So it can lead to all kinds of issues and wrongly blaming certain tissues that were felt in an MRI. Now, if the symptoms completely match the MRI, okay, then we know the MRI might be what's causing the problem, the tissue that showed up. But you don't want to get a scan until it's time to get a scan, is basically what I'm saying.
Yeah, it probably goes back to what you said is treat the person and not the scan. So we're looking at the person, what do they need to work on in regards to need their hip mobilized, do they need some lumbar range of motion, do they need some lateral hip strengthening, do they need some cardiovascular exercise to help them feel a little bit better and reduce the fear of movement? What do they need? Because the scan can also bring a bit of fear, you know, and because they're seeing a disc bulge and they think their back is popping out and things like that. But it's more, we look at what does the person need, and if a scan is warranted, absolutely the person needs a scan. But like Ciaran said, a lot of the time the conservative route is probably the most effective approach. Yeah.
Last couple of questions.
We're getting there.
I broke my shoulder over 6 months ago, but I still have slight pain. Is there any treatments that can help this? Absolutely. So, and again, if we break, I said in the clinic, we've got many different treatment modalities. If we break it up from a manual therapy perspective, where the therapist works on you, we can do all kinds of things to help your pain, increase your range of motion. Then, from the rehab side of things, obviously, correcting muscular imbalances, retraining motor patterns, etc., will all be shown to reduce your pain. Generally speaking, this is a general rule. The longer you've had something, the more the exercise-based approach should be the big treatment modality. Okay, so that's not to say that no manual therapy is warranted with something that's gone on for 6 months. It absolutely can. However, the exercise-based approach has been shown to be better in the longer term problem. And then the vice versa can be true as well in terms of some acute conditions respond really, really well to manual therapy. So that would be the thing I would say. It would be a multifaceted approach. But if you were to only go at one, it would be the exercise-based approach at 6 months later.
Yeah, I think, like you say, there's patterns lost there, there's strength lost, there's range of motion lost. And it takes, look, you broke your shoulder, it's going to take a bit of time to restore all those. 6 months might be enough, it could be an 8 or 9 months process. It depends on the individual, what we're seeing and what they need to work on. But for a shoulder, definitely the exercise approach is really important. If you think about day to day, we probably in general as a population, we don't use our shoulders enough. We don't do a lot of overhead a lot of the time, bar manual work. So if you're not doing that, we have to exercise it anyway, even if we're healthy and no injury. So when we've injured it, we have to put a real focus on increasing that rotator cuff strength, scapular control, neuromuscular control, and just get that general movement and full strength back.
And the shoulders is actually a unique joint in the body in the sense that most joints in the body, if we look at how the joint is stabilized, ligaments tend to do a lot of the work, but actually the shoulder is unique because it's the most mobile. Actually, our strength and muscle around there is actually the most important thing. So of all the things that, I mean, I don't want to play in any body part, the shoulders certainly, if you've got an imbalance in muscular strength around there, you can have a problem. And even the athletic population, so what we would see, this is a factor as long as I can remember, you can have an athlete who's extremely powerful in certain muscles around the shoulder, but they might, for example, have diabolically weak rotator cuff, and we know that inhibits your brain. Number one, increases your injury risk, but also it actually inhibits your brain and won't let you even exert as much power as you have because your body knows I'm not stable because my rotator cuff is weak. So again, all the more reason if you're a high-end athlete to get tested because you don't actually know. You could be bench pressing, let's just take a very simple exercise like a bench press, and we have a number. You could be stuck on a 100-kilo bench press for a long, long time, and actually your problem is your rotator cuff is weak. You strengthen your rotator cuff and get some balance through the shoulder, all of a sudden you can bench 115, 120. The power was always there, but your brain is inhibiting you and actually stopping you from doing it because it knows it's not stable. So shoulders, a big rehab and strength work around your shoulders is very, very important. Do you accept health insurance and how does that process work? So absolutely, any registered osteopath, physio, assuming they're proper osteopaths and physios and registered, you will be able to claim your health insurance. That will be very policy dependent. So a typical one might be you get 50% of your treatment fee back. Then we have one the other day, and the person gets €50 per treatment. It might be limited to 12 a year, but it could be 12 osteopathic treatments, 12 physio treatments. There's various, depends on the policy, so definitely check the policy. The other really, really important thing, and this is everybody, this is not just health insurance, is tax. Okay, so you can get 20% tax back on medical bills, and we're classified as a medical bill. Again, once it's a registered osteopath or physio. And so you could have a situation where, let's say you spend, let's just round up a figure of €100, right? You spend €100 and you get 50% of that back. Okay, so now you're €50 out of pocket on your health insurance after your health insurance, but you can claim 20% of that €50 out of pocket. So now you've actually paid €40 for your €100 treatment. So the treatment only costs you 40%. So those are things that you need to think about. We're not here now to do not Eddie Hobbs. We're not here to do financial talk. We could do that. But definitely, look, you need to like this is the government is actually saying to you, look after yourself. We will give you money to look after yourself. We have a reception team that will give you a receipt every time you come in. Get your money back. Get your money back and look after the pocket for sure. Can I still benefit from treatment even if I've had pain for years? Absolutely. Again, this is probably similar to an earlier question. The more long-term or chronic, the more exercise-based. But absolutely, we've had countless patients over the years that have had long-term outstanding problems, and we've been able to help them. Obviously, we recognise, generally speaking, the longer something is there, the harder it is to get rid of. And maybe it's not about getting rid of it. Maybe it's just about managing it. But generally speaking, we can help. That would be what I would say.
Yeah, absolutely. Again, exercise-based approach. You look at it, it's moving is medicine.
Absolutely. Second last question, why do women get so many ACL injuries compared to men?
So there's two main factors. I'll go into one, maybe Ciaran, you want to go into the other. So first of all, women, regardless, we have they're biomechanically a little bit different to males. So women have wider hips, so which is going to change the loading around the knee. So that's going to cause a bit more internal rotation in the thigh, which is going to cause a bit more internal rotation in the knee. Okay, so we call it knee valgus basically. So that is going to be a problem when we're changing direction, when we're landing.
So to show you what that looks like, it's when the knees are closer together.
Absolutely, yeah.
Okay.
It's a valgus
See that?
force, which can be a cause. It can be a cause of an ACL injury. So they have a bit more of a challenge to than a male with regards to their knee control, which means they need to probably work a little bit more on some hip strengthening, on some glute strengthening to help prevent that knee valgus pattern. And I suppose second of all is the hormonal side of things, Ciaran.
Yeah, so obviously there's many hormonal differences between a male and a female, and we could get an endocrinologist or an anti-aging doctor to try to explain this, but they're very different species hormonally. And the big difference from an ACL perspective is estrogen, which is obviously the primary female hormone. What it does is it actually affects cross linkage in collagen in tendons and ligaments. So effectively, in plain English, the higher your estrogen levels, the more lax your kind of connective tissues are. Okay, as opposed to a male where testosterone is the main hormone, it does the exact opposite. It actually stiffens the structures. That's one of the reasons why, for example, men have higher blood pressure than females, because again, the testosterone will cause a lot more stiffening of the connective tissues and the muscle in the walls of the arteries, versus estrogen dilates them and relaxes them, so women have lower blood pressure. Until post-menopause, when basically things start evening out. That's why women have much lower risk of heart disease, for example, until they go post-menopause, and then things start evening out. In terms of the ACL, what that means is a female with higher levels of estrogen, things are just more lax, and that is actually like estrogen will cycle. Okay, so coming up to the luteal phase, when they're coming to ovulation and estrogen is really peaking, that's when risk is even at its greatest. So look, there's so much to think about there. It can be hard to manage it, but it's just another factor. I think it's something like 4 to 8 times more likely that a girl will rupture an ACL to a male. So this is a real factor.
I suppose how to help prevent it is a regular strength conditioning program. So they're focused on the posterior chain strength, their quad strength, their knee control, being able to land with good control, good technique, change direction, good control technique, and for that to be a constant base of the part of their training.
Yeah, and even, you know, we could talk about this all day, but to me it emphasizes as well, we're seeing a lot more teenage girls with ACLs now. It's becoming really prevalent. And if you think about it, what happens to a teenage girl? It's puberty. Okay, so males and females are actually quite similar in strength and growth, etc. Then once they hit puberty, the male has loads of testosterone and the female has loads of estrogen, and that's when the problem starts. Okay, so to me, it's highlighting the importance of movement and strength growing up. Okay, so we know that kids are typically more inactive now, and so to me, it actually really emphasizes the importance of structured strength training for teenagers, to be quite honest. So look, I think it's an issue that's only getting worse, and I think parents really need to think about that, because if you want to try and reduce the risk of your particularly daughter having an ACL, you really think about strength training, because realistically, there's no other way of doing it. You know, that's the one thing about strength training. I generally say the best exercise is the one you'll do, which is good for general health advice. However, you know, to prevent injuries, strength training is the single factual best thing that we know of to do that. So having a proper healthcare provider that's actually running your strength program as a teenager is so important. Last question for the night is exercise pre-joint replacement a good idea? You want to take that?
Yeah, absolutely. Really good idea. I suppose you have to look at what you're going into to kind of understand the reason why. So somebody comes in and is getting their knee replaced. So the nature of the surgery, there's going to be a lot of muscles that are going to be cut through. So to replace the knee. What happens then afterwards, obviously, the knees get quite stiff post-operation. The first few days are going to be, or first few weeks are going to be really stiff, and we're going to start to lose. You're losing strength in the hours post-surgery, and we've lost function sort of back on gym crutches. Now, the opportunity there is before the surgery is that you can get your knee in the best condition possible and the muscles in the best condition possible for your surgery. So what that means is basically, yes, you're going to lose strength post-surgery, but if you do exercise and strength training before surgery, you can afford to lose that bit of strength post-surgery, but it not affect your function too much. What that means then is you're going to have a greater recovery from your surgery, and you're going to recover a little bit quicker, and you're going to be able to do day-to-day things that we take for granted, like walking without a stick, getting in and out of the car, getting in and out of the toilet, a lot easier, a lot sooner. So if we look at it in regards to exercise before a joint surgery, you want to think about it as in you're looking at it as a marathon. So you've got to prepare your body for the surgery so that you get the best outcomes after the surgery. If we don't do that, we're gonna struggle for the first while post surgery, because more than likely with a knee again, like for example, it's usually going on for 6 months, a year, sometimes it's 10 years. So they've got a chronic weakness around the muscles around their knee that they haven't addressed. And unfortunately, that's going to get worse post-surgery. So then that really limits your function in regards to just moving with crutches. So if you can start to address that chronic imbalance in strength, then you're going to have a much smoother journey through the surgery.
It's the very same as pregnancy that we said earlier. The stronger you are going into the surgery, the faster your recovery. That's the plain and simple answer. And the other thing about it is, and we know this from the athletic population particularly, if you know anybody that was once really strong and they get injured and they lose all their strength, you realize that they get back to their strength really quickly. Your body will actually remember how strong you used to be. And that's not reserved for athletes. Okay, so if you're getting ready to go into a knee replacement and you get yourself to a good solid strength level, your body will remember that. So when you're rehabbing, it will get back there very quickly. So the general consensus is the stronger you are going in, the faster your recovery. That's the simple thing. Gemma, any other questions there come in? No? That's it? Well, we will let you all go. Kath is hanging, he's been here since 3 o'clock this morning working. So thanks for tuning in. Hopefully, if people obviously comment in, let us know if you found that beneficial. If it's something that you found useful, we'll happily do it again. So yeah, have a good evening and we'll see you again. Thanks.